All right. Seizures. Is there a more misunderstood disease or condition or things that we treat than seizures? This is when you Google like seizure treatment, this is what comes up first. And you know, the way that I describe seizure, I described to a resident once this way, and I was sort of offhand just kind of saying it, but I think it's actually pretty good, is that in general, seizures, it's not something you want to see like out on the street or in the, you know, in the hallway in the emergency department or something like that. But for the most part, they're not actually all that dangerous. Most of the seizures that we're going to see are kind of okay, or will end up ultimately kind of okay. Seizures are relatively common among folks. Depending on what population you look at, anywhere from 0.5% to 20% of the population is going to have a seizure at some point in their life. Again, that's not that like 1 in 5 of us will have a grand mal seizure, but maybe something like it, and maybe in the whole course of your life, maybe you get something like that. So it's out there. Seizures are an abnormal neuronal discharge. And what does that mean? It means part of your brain that normally sends coordinated messages through the rest of it and allows you to move your hands or talk or breathe normally or act normally, cogitate, whatever you want to call it. Sometimes that doesn't work. Sometimes part of that signal gets a little bit haywire and part of the cells start like firing off on their own, and whatever part of the brain is firing like that, whether it's your temporal lobe or whether it's your frontal lobe that maybe controls like more cognitive kind of stuff, or if it's like balance or something like that, or if it's a motor section or a sensory section, whatever part is misfiring, that's the part that will manifest as something abnormal. So arm shaking, or if it's the whole brain, like in a generalized seizure, then, you know, maybe it's whole body loss of consciousness, something like that. So abnormal neuronal discharge. The way that I think about it is that your brain gets ticklish, essentially. Something sets it off. And what can be those things that set it off? Sometimes it's something that happens kind of right now. Something that is new, acute, an acute reason for you to have a seizure. Like your sodium is 105 where it should be 135. Or you're in renal failure, you've got bad sepsis, or you're hypotensive, or you're hypoxic, or severely hypercarbic, or something like that. Or maybe you've had an acute stroke or head trauma. You've got a blow to the head. And for whatever reason, part or all of the brain gets ticklish, a little twitchy. And when you do something to stimulate it, it starts firing stuff off. Just like if you tickle under your arm, you're like, ah! That kind of thing. Brain does that, except all, 30 billion brain cells or whatever go ah! All at the same time. And that causes the seizure. So there's acute reasons that could happen. Some folks have chronically ticklish brains. Some folks are just that's what they have. They have epilepsy, and so their brains seize like that, and you get relatively common, hopefully able to control abnormal neuronal discharge. Some withdrawal states will do that from drugs or other things like that, or alcohol. And sometimes you have CNS diseases that make part of the brain. Maybe it's a tumor, maybe it is a structural brain disease, maybe it's an old stroke that's left part of the brain more ticklish than otherwise. And so you get, again, just a little bit of meh in that area, and the brain, instead of like you would underneath when you tickle your arm, the brain goes seize, and starts firing off all this stuff. So there are different flavors or types of seizures, and we'll just kind of hit some. There's a few more than this. There's other things you can kind of have in there, but we can group them into the generalized seizures, the partial seizures, the absence seizures, and the non-epileptic seizures. We'll call it that, or non-epileptic spells, at least for government work that's close enough. So the generalized seizures are the ones where you lose consciousness. You generally lose, postural tone, you collapse, that sort of thing. And you are not conscious. You can't respond to stimuli. You can squeeze this person's arm, you can poke them in the arm, whatever it is, and they can't really move because their brain, in general, is firing off. And this can be associated with tonic movements, which is or colonic movements, which is like that. The stereotype kind of rhythmic stuff. Both those can happen. Or the person could just be flaccid. They could just be out, and their manifestation could just be that you have a loss of consciousness. And there's other things that can happen with it too. But the thing that makes it a generalized seizure is when you lose consciousness. There are partial seizures, like this little baby up here, what he's got, you notice that little arm, you may not really notice that the other arm is okay, it's moving around, but that arm is kind of held out like this, and it's going like this a little bit. That's a partial seizure. Part of his brain that controls that arm, somewhere over here, is firing abnormally. It's making the arm go like that. Now the rest of him is okay. He responds, he looks around, he's like, hey dudes, what's going on? That makes it not a generalized seizure. If he started to do this at first and was kind of looking around and then like lost consciousness and did more, then that may be a partial seizure that became generalized. But just one section without loss of consciousness, that's a partial seizure. There's these things called petit mal seizures or absence seizures, and this is normally things that happen in little kids, school-age kids. And if you watch this kid, you see how he's just kind of staring off there, like not really responding to anything. These kids get labeled as like daydreamers, and there he's back at it. He goes right back to normal. That was a little seizure, lasts 5-10 seconds, and he does not respond to you. He's just like literally staring off. But that's a result of abnormal discharge in his brain, not just him kind of, being goofy or something like that. And then there's the non-epileptic spell, the one down the corner here that I think I'm actually covering on the video. These are the ones that aren't a result of abnormal discharge of the brain. They're caused by usually psychogenic kind of issues with it. So we'll talk a bit more about those. After you have your seizure, with the exception of the absence seizures, there's usually some degree of a post-ictal phase. So ictal is like the seizure. Post-ictal is post the seizure, after the seizure. And this can be a number of different things. Basically, I kind of think of it again as you've tired the brain out because you've made it go boom, 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 a whole bunch. And then whatever areas were affected in the brain, those have got to kind of reset a little bit, and then kind of reboot. So if it was just affecting one arm, maybe it's just one arm. But there's all kinds of stuff that can happen. This can be anything from the standard, the guy's a little sleepy and then he kind of wakes up like that. It may be a little bit of disordered breathing. A lot of times there's amnesia with it. Sometimes folks have trouble in the post-ictal phase making memories. So you can get anterograde amnesia for a while or retrograde amnesia. These folks often will have trouble talking. They may have a focal neurological deficit. Move this arm fine, this arm not moving at all. Or odd sensation. Headache's pretty common. This tendency to just kind of like wipe your nose, that kind of thing, that's one of those post-ictal signs. You can have almost any kind of neurological symptom as part of your post-ictal phase. Now, usually the post-ictal stuff goes away relatively quickly. And relatively quickly means between 15 minutes and 45 minutes to an hour, something like that. Usually the person's kind of back to normal. A lot of times, if it's not a real prolonged seizure, 15 minutes, if it's been longer, they tend to be more post-ictal for longer. But under an hour, certainly, is about the time when we start thinking this is, a normal post-ictal phase. You can't have this prolonged post-ictal phase, and then you get a little bit more worried about them. But during this, the person usually gets a bit better. As an example, here's a post-ictal phase for this cat. He just had a seizure, and I think you'll start to hear him here in just a second. This can be, there he goes. This can be a little bit of a distressing time, maybe for the person, that's accompanying him, but for us especially, because it often looks like this person is not going to breathe very well. They're like, you could be like, GCS, intubate this guy or do a bunch of stuff, and I will tell you, resist that temptation. But he will eventually kind of recover. The other thing that can happen that we'll see fairly commonly is what's called Todd's paralysis. This affects anywhere from it's like 13 to 15% of people after they have a seizure. And what this lady had, she had a seizure, and now she's got incoordination and weakness in her arm. She can't really move it. Left arm is going just fine. Right arm's kind of, you can see, not really functioning. And she normally has normal function in there. Now, if you see this person who's, maybe arrived in their post-ictal state, and they're kind of like chilling, but like the right arm's not moving, that's, if I looked at it, I'd say like, oh man, does this person have a stroke? What is this? And in this case, it just happens to be Todd's paralysis. And so you can be reassured, and a lot of times we don't treat, folks that had a seizure that for like stroke right away, because a lot of times this gets better because it's just like the post-ictal paralysis, that kind of thing. A lot of times that will get better. However, to kind of scare you a little bit, somewhere between 2 and 5% of folks that have an ischemic stroke in the first 24 hours will have some seizure activity as well. So just because you had a seizure and then you can't move your arm doesn't mean it's just a result of the seizure. So it can be a little bit complex. And if they're not moving a part of their arm, the better part of valor is to say, this may be a stroke, we should treat it as a stroke. And again, what's treatment? It's rapid evaluation, that kind of stuff. But a lot of these folks will get better just because this is a result of the seizure and the side effects of that. And again, most of these folks, they get better. They have their seizure, they have their post-ictal phase, they feel tired, they may have a headache, they go sleep for a while, they wake up, and they don't feel like stellar, but they're okay. They're fine, they're their normal selves. No problem. The only problem is if they don't get better. And sometimes they don't. And this is the one where we really worry about it. The seizure itself, not that big a deal. Obnoxious, certainly bad if you fall in a pool and drown or if you're driving when you have it. That's why we tell these folks not to do that stuff. But one seizure in and of itself, generally not a big deal. It's when it continues on for a long time. That's when we really worry about the seizure itself. And status epilepticus is that seizure that continues on, doesn't stop. There's a couple of different definitions of it, depending on where you look at. It used to be a lot more broad, but the one that we've got now is a seizure that lasts more than 5 minutes. That's kind of the more accepted one, generally speaking, around the United States here. Or if you have 2 or more seizures without return to baseline. So when you have your seizure like that, and then your post-ictal period, even though he's not seizing right now, but if he goes back and has another seizure before he's totally awake and normal, back to normal, then that's actually status epilepticus. It doesn't have to be a continuous seizure. It could be a series of seizures without return to baseline in between them. That's one definition of it. There's another definition from the International League Against Epilepsy, which is just kind of a cool name, and so they get a cool slide. And this is maybe, depending on what your goal is, this may be more applicable for you. Maybe it's not a seizure that goes more than 5 minutes. Maybe it's a seizure that goes for more than 5 minutes after you start making an attempt to stop it. So you show up and the clock starts when you give them Ativan, Versed, whatever it is you're going to do, Diastat, whatever. If it continues on more than 5 minutes after you make an attempt to stop it, then these guys define it as status epilepticus. Now again, who cares? Because as I said, you can seize, and as long as you don't crack your head or fall off a building or drown or something like that, seizure in and of itself usually stops and it makes you feel a little bad, but it's not that big a deal. Who cares how long the thing lasts for? Well, the thing is that seizures are kind of like redlining an engine. The engine is kind of made to do that. Your brain can tolerate this okay for a while. But if you keep it going and you don't let it stop, eventually you're going to blow the thing. And the same thing happens with your brain. It doesn't happen right away, but it will eventually happen. So we go back to this guy. He starts seizing, and he's going at it. What's going on inside his body? If we take a look here, you have this blue line. Maybe it's a little hard to see. Your cerebral metabolism, as you start to seize, as designated by the corner down here, start seizing here. Start to seize. Cerebral metabolism starts going up. And it reaches kind of that maximum point somewhere around an hour. Let's call it an hour for ease of use. At the same time, because you're doing physical stuff and you're moving and maybe you're not breathing super well and all that kind of stuff, your anaerobic metabolism goes up, you start producing lactate, and aerobic metabolism goes up as well, and you start making CO2 as a byproduct of doing all that. So you're doing a physical thing, you're maybe not breathing real well, and your CO2 and your lactate start to climb, you start to get acidotic. You can tolerate that for a while, but it does, again, start taking off the longer that you go. Unfortunately, your body tolerates that stuff only so long. And again, right somewhere, maybe it's an hour, maybe it's a little bit beforehand, but let's call it an hour, you start to fall off the cliff. So blood pressure and heart rate and glucose all get liberated and go up in the short term. Once you hit that point, though, they start to fall off and you get hypotensive and cerebral blood flow falls and cerebral glucose availability falls. And now you've got a hyperactive brain with a bunch of acidosis and no substrate to go with it. And that means that the number of good brain cells you have starts to go down significantly. And again, that's somewhere right around, who knows exactly the actual number, but it's not certainly forever. And we'll call it an hour or so. And you may say, well, an hour, we got all kinds of time to stop it. Why are you talking about being so aggressive with treatment for it? The problem is that when you have a seizure, you take the typical guy that is seizing on the ground. Well, somebody somebody finds him. And then they think, oh, man, this is a seizure. Well, he's got seizures. Well, it's not stopping. Okay, we better call 911. So then it takes, 4 or 5 minutes to get 911 and get the call taker to figure out where you are and that kind of stuff. And then you got to dispatch somebody. And it's a couple minutes of shoot time and a couple minutes of, if it's in the middle of the night, we got to go there, or maybe we got to get en route, all that kind of stuff. And, then it's 5 or 6 minutes, maybe if you're in a city. And if you're out in the county someplace, it could be 15 or 20 minutes. And then we got to get there, and then we got to find the person. And then we kind of dilly-dally around, and we take a history, and maybe we do some stuff, and like have the EMT put them on the monitor and that kind of thing. You can burn up the better part of an hour in just getting there, realistically, for a good portion of the country. But then you got to make an attempt to stop it. And remember, an hour is not that long a time, especially if you're worrying about like putting in IVs and doing monitor stuff and that kind of thing. We want to be aggressive with these. The longer it takes to stop the seizure, the worse things get and the harder it becomes to stop it. So we got to stop it. We got to stop it relatively quickly. We do that, generally speaking, with benzodiazepines as our number one drug. We haven't really found one that works better, faster, and does a better job to start off with. We'll start off by giving a benzodiazepine of some kind. We'll talk about it. If that doesn't work, we'll maybe give another drug, or maybe just more benzos, maybe a different type of benzo. Third line, if that hasn't worked, maybe we'll probably give some more benzos, but we may consider another drug at that point, a true anti-epileptic drug like fosphenytoin or Keppra, something like that. That's our general treatment strategy. How does that actually apply? Well, you show up, let's say, this is the way I kind of think about it. I show up and I see a person who is seizing. I ask, well, is their airway okay? It's sort of okay. It's kind of tenuous right now, but I'm going to not mess with it a whole bunch right at the moment. It's good enough for government work. Is his breathing okay? Let's put a little oxygen on him, and we'll move on from there. We'll fix this here in just a second. And then I ask, do we have an IV? The reason I ask about the IV is because that's going to affect what I do next here. If he does not have an IV, I'm going to hit him with 10 milligrams of IM midazolam. If he has an IV, I'm going to give him 0.1 milligram per kilogram if it's a little kid, up to 4 milligrams of Ativan or lorazepam IV. So either 10 of Versed IM, or if he has an IV for some reason already, then I'll give him 4 milligrams of lorazepam. I'm going to wait 5 minutes after I've given that medication and then ask kind of the same questions. Is he still seizing? Is his airway still okay? Do we need to do anything else with it? Is he oxygenating okay, breathing okay as far as we know? Maybe we need to bag him. But do we have an IV yet? If we have an IV at that point, then I'm probably going to switch it up. I'm going to go ahead and give him 4 milligrams of lorazepam again, or in addition to what I gave before. If we don't have an IV, then I'm probably going to give another IM dose of midazolam, or I may give some other drug at that point. But for me, it's going to be, I'm going to give him IM midazolam first. I'm going to use the 5 minutes to probably start his IV and manage everything else, kind of get an idea what's going on. And then if he's still seizing, I'm going to give him 4 of Ativan. I could continue on after that. I give him another 4 milligrams of Ativan. Once you've had 2 good doses, though, that's kind of when we say, like, all right, this is probably refractory, and we need to kind of move on to other things. But a couple of good doses of benzos there. You're going to say, whoa, wait a minute. Well, you're talking about this 4 milligrams of Ativan like this is nothing. Like, oh, yeah, just give him that stuff. I give, a half milligram of Ativan or a milligram at most, and they tell me to give like 2.5 of midazolam. What's with this 10 nonsense? And I would say, well, we got to appropriately treat them. If you're given small doses, if you're given under these doses, I hate to say it, you're probably not doing it right. And it's not necessarily your fault. It's just we got to get up with the times. And what's the times look like? Maybe something like this. So these doses are based on a study that was called the Rampart trial, and it's really interesting. It was a big study that came out now 10-ish, a little more than 10 years ago, looking at pre-hospital management of seizures. And if you're just interested in like a bunch of different ways you can do pre-hospital research, this is an interesting thing that you can look at. Anyway, research guys love this, talk about it all the time. What this basically showed is that if you showed up and you got IM midazolam, 10 milligrams, or 5 if you're a little person under 40 kilograms, and that could be like kids under 40 kilograms. No other doses. You either got 5 or 10 IM versus 4 milligrams of lorazepam IV or 2 milligrams, if you're a little person. And you ask which one works better in terms of time to stopping seizure and that kind of stuff. You find that midazolam, the IM, probably works a little bit better, stops a little bit faster. And why is that? Midazolam, the IM shot may take a little longer to get absorbed, but you don't have to start an IV in a seizing person. So show up and hit them with 10 of midazolam, and that works as well, if not maybe a little bit better, than 4 milligrams of IV lorazepam. And again, that's 4 milligrams of IV lorazepam. That's not 2, that's not 1, that's not a half, and it's not 2.5 of midazolam, for God's sake. You give good doses, and we get good results. And by the way, this was adults and kids. It was kids greater than 13 kilograms, which is, 28 pounds, something like that, which is 4 or 5-year-olds, something like that. But this is okay if you give it. None of these people stopped breathing. None of them died as a result of hypoxia from getting too much benzos. You literally, it's almost impossible, not almost impossible, it's possible, but it's very difficult to stop a person breathing with benzodiazepines themselves if there's not some other thing going on. Benzos are safe. These are fine medications to give at these doses to anybody, just about. So, 10 milligrams IM midazolam is what he's getting from me when I show up. I'm going to then start an IV, deal with his airway, make sure he's got oxygen on, and by deal with airway, I mean some basic airway maneuvers. And then 5 minutes later, when I've got that stuff done, if he still sees, he's going to get another dose of either 10 IM of midazolam or 4 of lorazepam. And again, these are evidence-based, and this is the standard of care nowadays. If you're not doing this about just the way I said it, you're probably not meeting the standard of care. All right, well, what about the glucose, though? What if his glucose is low? Shouldn't we be checking the glucose and treating that before you haul off and give him a bunch of benzodiazepines? Well, maybe, and folks that have low blood sugars do have seizures, but how frequent is it when you look at the totality of it? When you actually look at the folks, and this is across the country, who had a fingerstick glucose less than 60 when they had their seizure call, this is it in the black lines. These are folks, and these are the folks that got treated somewhat empirically. And you notice it goes up as you get a little bit older, kind of peaks in middle age, blah, blah, blah. There are folks that are hypoglycemic when you get called for their seizure. I'll get it out here. But what's the actual percentage? If you look over here, 1%, 1.5%, something like this, out of looking at this blue bar, total of like 76,000 seizure calls. This little green one down here, that's the number that actually had low glucose. So it does happen, and that number was like 7,000, 1%, something like that, 1 out of 100. So yes, it does happen. You should check a finger stick, but most of the people are not going to be hypoglycemic. Way to the extent that you should probably do everything else first, and then yes, we'll get around to the glucose on the off chance that this is this person down here. But give them medicine first before you check a glucose, because most people are not going to be hypoglycemic. Don't not do it, just don't make it your first priority. Get it out of your mind is like, this is the first thing you need to do. The first thing we need to do, if airway and breathing are marginal, then and we can kind of fix those, is get them medicine on board, because everything else will get better once we stop them from seizing, generally speaking. Other considerations. What about a C-collar? These people fall, they hit their head, they collapse, they do that kind of stuff, they bounce their head all around. What about a C-spine? We always say C-spine first, right? Consider C-spine, number of patients, all that kind of jazz. They could hurt themselves if they fell off a building or they got in a car wreck or fell down some stairs. But in, again, a study of folks that had seizure activity and got looked at, got evaluated, how many of them actually had cervical spine injuries? 0. Not a single spinal fracture out of 1,700 patients, which is pretty good. Not impossible that it could happen again. If I fell off the stage here and plotzed my head down on the ground, or I fell off the top of a building or something like that, yes, If you believe that sea collars do something, then put a sea collar on them. But otherwise, don't worry about it. The sea collar's just getting in the way, especially if there's no significant mechanism. And again, I mean significant mechanism, not just like he bumped his head on the ground when he seized. What about the ABCs, airway, breathing, and circulation? I kind of been mentioning those a little bit. Again, most of these are going to get better, especially airway and breathing, when we get his seizure better. But resist the temptation to do anything invasive on these folks. Resist the temptation, definitely, to put anything in their mouth. Almost all these people, with very, very few exceptions, unless they are actively pouring blood or vomit out of their mouth and it's going in their air, going down their lungs, almost all these people will be maintainable with basic airway stuff. And a lot of times that is just like, don't lay the person flat on their back. Turn them into either a recovery position or sitting up a little bit and put oxygen on them. If you are going to do some sort of thing because they're like obstructing their airway because they've got sleep apnea or a big bull neck or something like that, and when they're starting to breathe, they're going that kind of thing, which sometimes does happen, do not put something in their mouth to try to fix that. You got two options. One is an NP airway, which they're unlikely to be able to like aspirate, whereas you put something in their mouth and there's every chance in the world they're going to gag on it or inhale it. So don't do that. But NP airways are great. Or if you need to bag them, do a good jaw thrust. Even if you're not needing to bag them, just a good jaw thrust will fix 85% of your airway issues. Good jaw thrust, two hands, and if you are going to bag them, do good bagging technique with two people. Don't try to do the one-handed thing because you cannot hold a one-handed mask seal and make it worth a damn. So the basic airway stuff is all you need. Resist the temptation to do anything else with these folks, including putting an iGel or an LMA or a King airway down there. Well, when do I intubate him? He comes out of this. I mean, look at this guy. He's he's a solid GCS 4, 5. I guess his eyes are open, so he can't be like a 3. But he's not talking to us. He's not moving. So I guess that makes him a 6 at the most. And GCS less than 8. Let's intubate. The problem is that his GCS less than 8 maybe lasts 10 minutes. And if we get him through that, all of a sudden he's this guy. And he's okay. And he doesn't need intubated. And you've done a bad thing. Maybe not a bad thing. You've been misguided if you for some reason gave him a bunch of medicine and stuck a tube down his throat. You support these folks, and then they will almost always get better, and they so rarely need to get intubated or have advanced airway management. Let's say there's the occasional guy that does. I had a guy when I was a resident we futzed around with for an hour. We gave probably a total of 48 milligrams of Ativan. We gave some Versed. We found some Valium someplace. Somebody came in with some phosphenatone because Keppra wasn't really a thing at the time. And at the end of this hour, he's still seizing. His airway reflexes are poop. And we're like, all right, well, we got to intubate this guy. What am I going to do if I absolutely have to intubate this guy? Maybe he's throwing up stuff, and there's just no way to do it otherwise. And we got to keep his airway okay. And I don't think I'm going to be able to do it with the basic stuff. Here's what I'm going to do if I'm going to intubate this guy. I'm definitely going to RSI him. I'm using drugs. There is no way you're going to like take this seizing person and safely jam a tube down his throat. Nah. What I'm going to do is I'm going to give him enough sedative in the form of propofol that he is going to be asleep, and I'm just going to keep pushing the propofol till he either gets super hypotensive or he's out, and I don't see him seizing anymore. And by the way, propofol is a great agent for that. And then I'm going to give him some paralytic as well. Now, there's some other drugs that you could give with him. You could use ketamine to do it. I would go on a heavy dose, probably 2 milligrams per kilogram IV rather than like 1.5. I would go heavy on it. You could use etomidate if you had to. It's not my favorite. It's pretty short acting, and I don't know. It's just not. As far as I know, nobody talks about how great etomidate is for seizures. I know propofol is great for seizures. Ketamine's pretty good for seizures. Etomidate, if it's what I got and I got to do it, then okay. But again, I am going to give him some succinylcholine with this. Suck specifically because it's short acting, and in about 10 minutes, he's going to be back to moving around again. I'm doing that because, yes, if I give him rock, he will not shake for 40, 45 minutes, something like that. But that doesn't mean that his brain is not continuing to fire abnormally and that it's not continuing to do all the bad stuff. We just won't know about it because we paralyzed his muscles. So I am going to use a paralytic. I'm going to do that because I'm going to make my first shot my best shot and improve the chance of first pass success, because when we don't do that, then we screw things up and things get worse with each subsequent one. I'm going to give him a paralytic. I'm going to know that in about 10 minutes he's going to be moving around again if that's appropriate for him. And again, my favorite drug for this is propofol. If you had to pick other stuff, again, midazolam is not bad. I'd probably do a hefty IV dose, maybe 10 milligrams IV midazolam if I was going to do it. Not my favorite. Again, propofol, better, easier to titrate, but could be okay. And good for post-sedation stuff too. Again, you give somebody, if he continues to seize, give him 10 milligrams of IV midazolam, you could do that. What's not a good idea is a long-acting paralytic, as I kind of mentioned before, because while you will paralyze his muscles and you won't see him seize, his brain continues to go beep, 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 and continues to have that seizure activity. And you know, you're not helping anything just by hiding the seizure activity. So don't give him long-acting, vecuronium, something like that, or rocuronium. If I'm going to do it, I'm going to do a short-acting paralytic. Not good is this stuff. Bear in mind, too, that maybe we don't want to pussyfoot around, or maybe we don't want to screw around on scene for very long, because while the folks with epilepsy have reasons to seize, folks that acutely seize otherwise, it's usually not good. It's not great. It's because, again, their sodium is super low and we got to know about it, or because they have a terrible head bleed and we need to know about that. And maybe he needs to go someplace and get, blood pressure management or blood products or, surgical control of this stuff. This stuff happens a lot out there. So don't forget, we want to do good neurocritical care with all this as well. Don't let these folks get hypoxic. Don't let them get hypotensive if you can help it, because they often, that first time seizure or that new seizure, oftentimes it is associated with something really bad. Sometimes not. Oftentimes it is, though, and they need some good treatment. There are some sort of atypical signs to look for seizures as well. They're not all the shake or the partial seizure. Sometimes this can be anything from just repetitive movements, going like this, or the guy that's not awake but he can't talk to you or anything. You don't see movement in his arms or legs, but his tongue's going. Maybe that's a seizure. The guy that just wakes up and then goes back unconscious, that could be seizure activity. It doesn't have to necessarily be anything that is, big movements. They could just be flaccid, or they could just be rigid and going like this, or something along those lines. Eye deviation is what we commonly kind of see, repetitive eye movements. Even yawning, repetitive yawning can be seizure activity. There's all kinds of weird frontal lobe activity as well that folks will get, which is interesting, like YouTube videos from like an epilepsy monitoring unit. While we've talked about sort of the abnormal neuronal discharge and how to aggressively treat that stuff, there's another group of folks, if you'll remember me talking about it, who are having seizure-like spells but are not actually having abnormal neuronal discharge. And these are the folks that have the psychogenic PNES, psychogenic non-epileptic spell or seizure activity, PNES, the pseudo-seizure. These folks are, admittedly a little frustrating to deal with. Mostly, I think that's kind of coming from us because we're like, there's nothing wrong with this guy. He's just crazy, for lack of a better term. And maybe that's a little bit pejorative, but certainly when we see somebody that doesn't have an actual medical problem and we're medical providers, we get a little bit frustrated. Understand that. It can be hard to tell, though, who's got the psychogenic seizure activity or spell and who's actually seizing. So this is a guy who is having a non-epileptic fit of activity, if you want to call it that, a spell. When you look at him, like, this isn't real convincing. Anybody that's seen somebody seized any significant amount, like, that's not real convincing. We may say that's a pseudo-seizure. The problem is that folks that have epilepsy also very frequently have pseudo-seizures or non-epileptic spells. That happens. Now, when he gets to something like this, where he goes like this thing, I might think that is an actual seizure. Like, that doesn't look unconvincing for it. He's going to start now he starts kind of doing this stuff a little bit more, and now we're like, all right, well, yeah, that doesn't look like a seizure. It's too fast. It's too kind of rhythmic and coordinated and that kind of thing. But you'll notice this guy goes on for a while, and it's not that he's trying to do it. It's not that he's intentionally wasting somebody's time. It's just something that's happening to him, and he probably doesn't like it any more than you do. So you do have to watch out for that. And again, these can look like seizures, or seizures can look like things that you would think, the longer I do this, the more I think like, that guy's not seasoned. And sure enough, he was seasoned. What do you do about it? You treat it. Really, yeah, I mean, you could say like, oh, don't give this guy medicine. Well, why? What's it going to hurt? If he's got a non-epileptic spell and you give him 10 milligrams of Versed and he falls asleep and then wakes up a bit later, as long as you take care of him and you don't let him get hypoxic and you like do, basic airway maneuvers and that kind of stuff, then you fixed his seizure. You've gotten him to the hospital. You kind of achieved your goals. You can get him plugged in with somebody else or get him referred. And why really lose sleep over it? And the good thing is that if you've treated it and it was actually a seizure, which again, sometimes it's hard to tell, oftentimes it's hard to tell, you have not just let this guy seize for 45 minutes while you're messing around with him. These are good things. This is a reasonable thing to do. If it looks like he might be having a seizure, just treat him. The medicine's safe. You know how to take care of the side effects of that medication. Just treat him. Fix it up, and then you don't have to worry about it. And if it was a seizure, cool. If it was an epileptiform thing, then like, all right, you've done a good thing. And if it wasn't, all right, you've still fixed it. All right. To sum up right quick, you show up. If the guy's seasoned, he's probably been seasoned for more than 5 minutes, thereby meeting the definition of status epilepticus. Go ahead and treat that guy. How are you going to treat him? I would give him 10 milligrams of midazolam IM to start off with. I would put oxygen on him, maybe slide an NP airway down his nose. If I have to, I'll assign an EMT or a partner to maybe hold his mouth open, and I'll start an IV, or I can start an IO. IO is fine as well. And if he continues to seize, then I'm going to give him 4 milligrams of Ativan IV. And again, let's say this kid, we didn't really talk about peds very much, but let's say this is an 8-year-old kid. Okay, he's under 40 kilograms, which is about 80, 90 pounds. Instead of giving him 10 of midazolam, I'm going to give him 5. And when we get to the Ativan, I'm either going to give him a weight-based dose at 0.1 per kilo, or just give him 2, cut the dose in half, which is also fine. But we're going to aggressively treat this guy, or this gal, or this kiddo. We give him IM first, then I'll give him some IV Ativan after that. And I'm not going to intubate. I'm going to do everything I can not to intubate this guy, because if I can just stop the seizure, then everything else is probably going to be temporary, and I just got to support him through it. So basic airway maneuvers are best, and it will fix 85, 90% of your problems otherwise. I'm not going to put anything in his mouth. If anything, I'm going to put an NP airway in his nose, which is a great thing. You absolutely must check a finger stick sometime, but it shouldn't be first. Treat his seizure first, and then check the finger stick, because again, it's pretty uncommon for the total number of seizures out there. And then the non-epileptic spells, don't forget, also respond to benzodiazepines in the same way that epileptic spells do, or epileptiform stuff.